Hello and welcome to today's presentation, Hippocrates was right, treating fever is a bad idea. My name is Julia Lemire and I'm the Lectures and Events Manager for the College of Physicians. I'll be joined today by College of Physicians Fellow, Dr. Paul Offit, the Director of the Vaccine Education Center at the Children's Hospital of Philadelphia, as well as Professor of Vaccinology and Pediatrics at the University of Pennsylvania School of Medicine. We're glad to have you here today. I'd like to briefly review our webcast protocol. The presentation of today's webcast will run about 30 minutes with the Q&A portion to follow with pre-compiled questions from our audience. I'd like to give a warm introduction to College Fellow and today's speaker, Dr. Offit, the Director of the Vaccine Education Center at the Children's Hospital of Philadelphia, as well as the Maurice R. Hilleman Professor of Vaccinology and Professor of Pediatrics at the University of Pennsylvania School of Medicine. Before we begin, I'd first like to say that we are very excited for the response to this presentation. It's the first online event presentation the college has put on in this capacity, and we'd like to thank everyone for signing up and attending, as well as making a donation during these times. All right, let's begin, Dr. Offit. You can take it away.
Thanks, Julie, and thanks to the College of Physicians of Philadelphia for setting this up. I actually have a book coming out tomorrow. It's called Overkill, When Modern Medicine Goes Too Far. And basically it's about all those situations in modern medicine for which there's abundant scientific evidence that we shouldn't be doing something, but we do it anyway. So one of them, and actually the first chapter, is that treating fever can prolong or worsen illness. There's a number of other things that I go through. One is that you actually don't have to finish the antibiotic course, that vitamin D supplements are not a cure-all, that certain cancer screening programs are not what they're cut out to be, and then some sort of common beliefs that are incorrect, like that vitamin C can treat or prevent cold. So it goes through about those 15 or so instances where that's true, that we shouldn't be doing something, but we do it anyway, and then talks about why we do continue to do that anyway. So in any case, we'll start off with treating fever and why it's a bad idea. So why is it that every warm and cold-blooded animal that walks, flies, swims, or crawls on the face of the earth for the past 600 million years has the capacity to make fever? Isn't it possible that fever is part of our immune response, adaptive to our environment? And isn't it then possible that reducing fever might prolong or worsen illnesses? So we'll start at the beginning, fever therapy. There was a time in this country when we used fever therapy, when we used fever to treat infections. This was probably best shown on a 2-year Cinemax series called The Nick, about a fictional New York hospital in 1906 called the Knickerbocker. The film starred, or the show starred, Clive Owen, who you see sort of there performing surgery in the center of this screen. And one of the things that they talked about was I'll show you here in this slide. The person who was the archivist for this show, the sort of medical consultant, was a guy named Stanley Burns, who runs the Stanley Burns Archive in New York City, which is the largest collection of these old sort of medical photographs. And so one thing that they talked about on this show was shown on this slide. So here's a surgeon operating on a patient under ether anesthesia, and he's cauterizing a wound. And what happened actually many times during these kinds of surgical procedures is that the physician or the patient would catch on fire. Ether was highly flammable. This was shocking, I'm sure, to the audiences, but was actually medically accurate. Another thing that was medically accurate was how syphilis was treated. So this was the actress's name was Jennifer Farron. She played the girlfriend of the protagonist in this show. And she was suffering from syphilis, and you can see the enormous cartilage damage to her nose caused by this particular bacteria. So one of the ways that this was treated, and it's shown, you can see on the bottom, it says the Nick, because this was taken from the Nick, but this is an actual picture of someone undergoing fever therapy. So what they would do with people with syphilis or with gonorrhea is they would put them in a fever box, essentially baking them to increase their fever, because bacteria like Treponema pallidum, which causes syphilis, or Neisseria gonorrhea, which causes gonorrhea, was exquisitely sensitive to high temperatures. So fever therapy worked. The other way that physicians generated fever was to inject people with malaria parasites, also medically accurate. The person who pioneered that approach was Julius Wagner Jauregg. So here in this picture, again accurate, you can see Dr. Jauregg on sort of a little bit to the right of center, while he's supervising the injection of someone with syphilis with malaria parasites. Now this is the early 1900s, so quinine was available. So after injecting them with these parasites, having them go through days of high spiking fevers, he then would give them the quinine that would kill those malaria parasites, for which he won a Nobel Prize in 1927, for, as it says at the bottom, for the discovery of the therapeutic value of malaria inoculation in the treatment of dementia paralytica, which was essentially tertiary or late stage syphilis. Interestingly, malaria therapy was actually used to treat a number of infections, actually well into the 1950s, remarkably enough. Okay, so if treating fever helps with illness, at least in these settings, does treating fever with antipyretics, with anti-fever medicines, actually worsen illness? So there's a number of ways to look at this. The first was with experimental animals. So these were the famous Matthew Kluger lizard experiments. So what Dr. Kluger did, who was a physiologist, is he injected lizards with a potentially fatal dose of a bacteria called Aeromonas hydrophila, and then placed these animals in chambers with varying temperatures. At 93 degrees Fahrenheit, 0% of the animals survived. At 97 degrees Fahrenheit, which is normal lizard temperature, 25% survived. And at 104 degrees Fahrenheit, most survived, 75% survived. Again, fever, being allowed to have fever, allowed these animals to survive this infection with Aeromonas hydrophila. Then what he did was he injected the lizards again with Aeromonas hydrophila and treated them with either an antipyretic or with placebo. So antipyretic is just an anti-fever medicine. The lizards that were allowed to increase their body temperature by entering a high temperature chamber survived for 1 week. But the lizards that were treated with an antipyretic were dead in 3 days. Again, experimental evidence that fever was curative. There are many other animal model studies that have been shown here. So ferrets infected with influenza, dogs infected with herpes viruses, goldfish and sockeye salmon infected with Aeromonas, mice infected with Coxsackie virus or polio or herpes virus, rabbits infected with pneumococcus, Staph aureus, E. coli, Pseudomonas, Streptococcus, Pasteurella, Myxovirus or Vaccinia virus. In every one of these cases, in every one of these animal model studies, giving anti-fever medicines reduced the capacity of the animals to survive. So there has not been, to date, an experimental animal study that showed that giving fever-reducing medicines is anything other than harmful. So what about people? There are a number of human studies which I'll go through now. And again, there has not been a human study that has shown that antipyretics actually lessened the length of illness, reduced the length of illness, or reduced symptoms. So in 1975, researchers at the University of Illinois College of Medicine inoculated 45 adult volunteers with rhinovirus. Half of the volunteers were treated with aspirin and half with placebo. The aspirin-treated patients shed virus significantly longer than placebo-treated patients. In 1989, researchers at Johns Hopkins Hospital in Baltimore studied 72 children less than 12 years of age who were infected with varicella, chickenpox. Half were treated with acetaminophen, which is Tylenol, and half were treated with placebo. The time to healing of all blisters was significantly longer in the Tylenol-treated group. In 1990, researchers at the University of Adelaide in South Australia inoculated 60 adult volunteers with rhinovirus and then treated them either with aspirin, acetaminophen, which is Tylenol, ibuprofen, Motrin, or placebo. Those treated with antipyretics shed virus for longer, had lower or lesser antibody responses, as well as worsened congestion, coryza, which is just runny nose, sneezing, sore throat, lymphadenopathy, which is an enlargement of lymph glands underneath the jaw, and cough. In 1992, researchers at the University of Helsinki in Finland studied 102 children with Salmonella gastroenteritis. So Salmonella is a bacteria that infects the intestinal tract. Children without fever shed bacteria in their stools for 12 days. Children with fever, greater than or equal to 104 degrees Fahrenheit, shed bacteria for only 2 days. Again, fever was curative. In 1994, researchers at the Fujimoto Children's Hospital in Japan studied 208 children with fever and upper respiratory infections. Half of the patients received frequent doses of Tylenol or acetaminophen and half didn't. Those treated with antipyretics were more likely to develop pneumonia requiring hospitalization. In 2000, researchers at the University of Maryland School of Medicine inoculated adult volunteers with influenza or Shigella, which is a bacteria that causes intestinal infections. Half of the patients were treated with aspirin or acetaminophen, and half weren't. The subjects treated with antipyretics had illnesses lasting 3 to 4 days longer. In 2005, researchers at the University of Miami School of Medicine studied 82 patients admitted to the trauma intensive care unit. Half of those were treated aggressively whenever they developed a fever, and half weren't. And remember, trauma itself, because it causes a great amount of tissue damage, can itself cause fever, even absent a viral or bacterial infection. Those treated with anti-fever medicines were more likely to develop infections and more likely to die from those infections than those who weren't treated. Again, paralyzing the immune response by giving an antipyretic was a bad thing. In 2006, researchers in Hungary summarized studies that examined the relationship between fever and survival in patients with sepsis. Sepsis is just an overwhelming bacterial infection of the bloodstream. The mortality rate was 22% in patients with fever, 31% in patients with normal temperatures, and 47% in patients with temperatures less than normal. Again, fever protected you against death from bacterial sepsis. So what happens when we treat fever? Why is it that treating fever seems to cause a worsening or prolongation of illnesses? So that's shown on this slide. If you look at the sort of the big purple cell in the center, what happens is when you're infected with a bacteria, as seen on the left, or infected with a virus, or have other reasons to have fever, that cell makes something that's called endogenous pyrogens. Pyrogen is just fire maker. Endogenous means inside the body. So those endogenous pyrogens have names like interleukin-1, tumor necrosis factor, interferon alpha. What those proteins do is they then travel to the hypothalamus, which is located deep into the center of the brain, which then causes an increase in production of something called prostaglandin E2, which then increases your temperature set point. Now, pretty much all these drugs that I was talking about, like aspirin or like ibuprofen or like acetaminophen, Tylenol, all work at the level of prostaglandin E2. They all decrease prostaglandin E2. They all sort of work against what your body is trying to do, which is to increase prostaglandin E2. And what that does is it increases your set point. So you feel cold. You want to get warmer. You put on heavier clothing. You get under the covers. You put a log on the fire. You shiver. So that's another way to generate heat. You shunt blood from your hands, your nose, your arms and legs to your core to try and increase your body temperature. Your body wants you to be warmer and warmer because it knows that at a higher temperature, good things happen. And I'll tell you what those good things are in the next couple slides. So why does fever enhance survival? Why is it that we're all willing to pay this metabolic cost for fever? Because for every degree centigrade that your body temperature increases, that causes a 12% increase in your basal metabolic rate. We pay a high energy cost to have fever, but we're willing to do that every time we're infected for a reason. And the reasons are shown on these next couple slides. First, your innate immune system works better at a higher temperature. And by innate immune system, I mean the thing your body initially does when you're infected, for example, with a bacteria. It sends white blood cells called neutrophils, which are the white blood cells that you see in pus, that then travel to the sites of infection better and more efficiently, ingest and kill bacteria better and more efficiently at higher temperatures than lower temperatures. This explains the studies then that showed why those anti-fever medicines worsen bacterial infections like Shigella, bacterial pneumonia, and bacterial sepsis. Similarly, your adaptive immune system works better at a higher temperature. So your adaptive immune system is that part of your immune system that when confronted with a pathogen like a virus or a bacteria, makes antibodies specifically to that virus or bacteria. So this is a more specific component of your immune system. What has been shown redundantly is that B cells and the kinds of cells that help B cells make antibodies, so B cells make antibodies, helper T cells help B cells make antibodies, are more efficient at higher temperatures. This explains the studies showing that anti-fever medicines lessened antibody response or prolonged symptoms in patients with viral infections. One thing that's interesting is that fever also works locally. So for example, for those of you whose mothers recommended chicken soup when they had colds, there actually was a logic to that. And it had nothing to do with the chicken or with the noodles or with the celery or with, if made correctly, the dill that was in the chicken soup. Rather, it had to do with the temperature. So this study was done by a group of physiologists at Yale. And what they did was they found that that rhinovirus, which is a very common cold virus, very common cold virus, reproduced itself better at temperatures found in the nasal cavity, in the lining of the nose, which are really about 2 degrees cooler than your core body temperature. Your nose is about 2 degrees cooler than your core body temperature, and these viruses actually reproduce themselves better at that lower temperature. They found that when the temperature was increased to sort of normal body temperature, which is 37 degrees centigrade or about 98.6 degrees Fahrenheit, they found that at those higher temperatures, they induced levels of something called interferon, which is an antiviral protein that your body makes, as compared to cells that were infected at 33 degrees. And they concluded that rhinoviruses replicate preferentially at nasal cavity temperatures due in part to a less efficient antiviral defense response of infected cells at cooler temperatures. So that steam that was provided by eating the chicken soup was actually lessening the amount of virus that was reproducing in the nasal cavity. So your mother was right. How about vaccines? This is common. Many pediatricians, in order to avoid fever that is associated with getting a vaccine, because a vaccine is also a challenge to your immune system. Your immune system is to some extent revved up to be able to respond to that vaccine, and often that revving up is associated with fever. So the thinking was, okay, to avoid having fever associated with vaccination, let's give antipyretics, which many physicians do. So in 2009, researchers in the Czech Republic divided 459 children into 2 groups. One group received acetaminophen or Tylenol every 6 to 8 hours, the other didn't. There was a significant decrease in antibody responses to a variety of vaccines, including the pneumococcal vaccine, the Haemophilus influenza type B vaccine. Both of those are bacteria that can cause sepsis and meningitis and pneumonia, the diphtheria vaccine, the tetanus vaccine, and the whooping cough vaccine, which persisted after booster dosing. So in other words, even after you got your first round, which lessened the response, even when you got subsequent rounds and that you didn't treat with anti-fever medicines, that lesser immune response still persisted. Similarly, in 2018, research in Australia examined more than 3,000 children given an influenza vaccine who did or didn't receive anti-fever medicines. And what they found was antipyretics significantly lowered influenza-specific antibody responses. I think giving anti-fever medicines at the time of vaccination is one of the least informed things we do in medicine, arguably one of the more harmful, considering that it lessens your immune response to the vaccines that you're giving. How about antipyretics or anti-fever medicines and society? This was a study that was published in the Proceedings of the Royal Society out of England. But in 2014, researchers in Canada found that people who use antipyretics during influenza season were more likely to shed virus for longer periods of time and more likely to leave the home and spread their illness. You feel better, so you leave. They found that societies that used antipyretics more frequently suffered a 5% increase in influenza cases and deaths, and estimated that avoiding antipyretics at the society level would save 700 lives in the US and 40,000 lives in the world a year. So why do we treat fever? There's 3 main reasons, only one of which, frankly, makes sense. Although, as we know, there's a price to pay for treating fever. So one is to prevent brain damage. I mean, there are people who worry that your temperature can get so high from your infection that it can actually permanently harm your brain. Now, as it turns out, natural or physiological fevers don't cause brain damage. They don't. Your body never makes a temperature, it causes you to have a temperature so high that it damages you. It doesn't, assuming that you're not infected with a bacteria or a virus that actually infects the brain or infects the lining of the brain or spinal cord, that the natural or physiological response that you have doesn't cause brain damage. Now, that's not true for environmental fevers. So in other words, for those athletes who are, say, football players that are out there in heavy clothing during summer months and they're sweating, and that heavy clothing doesn't allow them to dissipate heat through sweat, they can have problems. Outdoor laborers, military personnel can suffer something called heat stroke. For example, recently an offensive lineman who played for the University of Maryland's football team died of heat stroke. Heat stroke is characterized by confusion, headache, dizziness, muscle breakdown, kidney failure, multi-organ failure, and death. And heat stroke causes about 600 deaths a year in the United States. But environmental fevers don't cause harm. Now, so you could argue, going back to the original story I was telling you with that television show, The Nick, injecting someone with malaria parasites won't cause brain damage because the fever that you're making there is a physiological fever. But putting them in the fever box could, because there you're sort of overriding the body's natural desire to make fever and imposing a fever upon that body. The second reason that people give for using antipyretics during illnesses characterized by fever is to prevent something called febrile seizures. So febrile seizures are common. They occur in about 5% of children between 6 months and 5 years of age, but they're benign. Children with febrile seizures are indistinguishable developmentally from children who don't have those febrile seizures. They're hard to watch. My daughter actually had a febrile seizure when she was 2 years old. So typically you have sort of this shaking of arms and legs, the head turns to the side, the eyes roll to the side, and this can last for 30 seconds, a minute, but feels like about an hour because it's so hard to watch. And the concern then is that this would then lead children to be more likely to have epilepsy, which is not true, or cause children to have developmental problems, which is not true, or any sort of subtle forms of brain damage, which is not true. More importantly, a recent review of 26 randomized clinical trials of 2,470 children showed that antipyretics don't prevent febrile seizures, because it's really not the height of the temperature that is the problem. It's the rapid rise in temperature, which is often hard to predict, and it doesn't work anyway. The third reason, and this makes the most sense, although we pay a price for this, is to feel better. Treating fever lowers the metabolic rate and lessens the symptoms such as headache, muscle weakness and fatigue. But the fact is, you're not supposed to feel better. You're supposed to stay under the covers, stay warm, and ride out that infection, not to leave the house and spread the infection to others. We have fever for a reason, and our body wants us to be warmer. I'll give you a sort of an example that happened actually at our hospital. There was a child who was a soccer player. While playing soccer, he hit his hip with a soccer ball, which caused him to have something called a septic thrombophlebitis, which just means a bacterial infection of the vein in his hip. The bacteria that was causing that infection was MRSA. So that's a resistant strain of Staph aureus, which can be brutal. There are antibiotics for that. Vancomycin is one example of an antibiotic that can treat MRSA infections. But what happened to him was the bacteria that was in his vein spread to his lungs and caused lung abscesses. It spread to his brain and caused brain abscesses. It spread to his joints and his bones, causing abscesses in his joint and his bones. He was sick, and every day he had fever. Every day he had bacteria in his bloodstream. Day after day, despite treating him with antibiotics, he had bacteria in his bloodstream. So what we did as an infectious disease division at Children's Hospital of Philadelphia is we sat down with the boy, sat down with his parents, sat down with the nurses, and explained you don't need to give him this sort of rotating ibuprofen and acetaminophen every couple hours. Let him have fever and see what happens. this boy was great, as were his parents. They were willing to do that because they were desperate that he was so sick and that he continued to have bacteria in his bloodstream that we stopped his antipyretics and let his neutrophils, the white blood cells that were trying to kill his bacteria, let them act more efficiently, let them kill more efficiently, let them ingest the bacteria more efficiently. And with that, the bacteria disappeared from his bloodstream in about a day and a half, after having been there in his bloodstream for more than a week. Now, maybe that would have happened anyway. Maybe it was coincidental, but I can tell you neither the nurses nor the doctors taking care of him, nor the parents, nor the child thought it was anything other than what we had done by stopping his anti-fever medicines. Now, pharmaceutical companies haven't helped here. They have been pushing anti-fever medicines since they were first invented. For example, aspirin was the first of the anti-fever medicines invented in 1895. Tylenol was invented in 1955. Let's get that temperature down. Let Tylenol do this job for you. And ibuprofen, which was invented in 1974. So what you have, as is true, I think, pretty much in every chapter that I write in this book, you have on the one hand clear scientific evidence that we don't do something, shouldn't be doing something, and on the other hand, a tremendous marketing strategy working against that advice. So is this a standard of care? In the pediatric world, there's a physician named Barton Schmidt, who's an older physician now at the University of Colorado, who has this sort of Barton Schmidt protocols. And it's interesting that he actually doesn't highly recommend treating fever. So for example, in these protocols, he argues that the average rectal temperature is about 98.6 degrees Fahrenheit or 37 degrees centigrade, but can range from anywhere from 96.8 degrees up to 100.3 degrees in the evening. The average oral temperature is about 97.6 degrees, but can range anywhere from 95.8 degrees in the morning to as high as almost 100 degrees in the evening. So there is this temperature range that one needs to be aware of. He argues not treating fevers up to 102 degrees Fahrenheit. He argues for treating fevers up to 104 if it causes discomfort, and greater than 104 that you should always treat. But Barton Schmidt and I just recently worked on a paper that we submitted to Pediatrics just a couple of days ago, talking about how to treat fevers in COVID-19. And after reading the chapter that I wrote, and he's a great guy, Barton Schmidt, he and I both agreed that there was no temperature that needs to be treated, including temperatures up to and greater than 104 degrees Fahrenheit. So our recommendation in that pediatrics paper is not to treat fevers associated with COVID-19, to give children every chance to get better from their infection. So Hippocrates was right, as this is the sort of lead title of this dissertation. And so what did Hippocrates say? So Hippocrates believed that a disease occurred when one of the four humors, black bile, yellow bile, blood, and phlegm, was produced in excess. The purpose of fever, argued Hippocrates, was to cook the raw humor, which then led to healing. He believed that fever was an important response to infection, not an innocent bystander. So Hippocrates was right. Okay, maybe he wasn't right about the four humors part, but he was definitely right about the cooking one of the four humors part, which is to say that fever really was an important part of responding to infections, not an innocent bystander. So there are a number of questions that have been submitted, that was kindly submitted by people that presumably are currently on this little seminar. And so actually you asked about 16 different questions. I'm not going to do that many, but I will do sort of a critical few that you asked. So one was, if Hippocrates was right that treating fever was a bad idea, why did today's doctors seem to ignore that advice? Right. I think the answer to that question is that as physicians, we want our patients to feel better. And we know that when we treat fever, that they will feel better, that that with the temperature coming down, they won't have the muscle aches. They won't have the shivering. They won't have the sometimes queasiness that is associated with high fevers, the chills that are associated with high fever. It's not pleasant to have a fever. It's hard to have a fever. I mean, there's a metabolic cost for fever. So I think that's why. And I do think that although there is abundant scientific evidence that shows us we shouldn't be treating fever, that either that evidence is not clear to physicians, because they just don't know about it, or they know about it, but know that to go up against this just cultural notion that treating fever is the right thing to do. I mean, to argue against treating fever, which I'm doing in this book, similarly arguing against that one doesn't need to finish the antibiotic course, which is also based on abundant scientific evidence, is to argue against a major cultural phenomenon that we're doing currently in this country and in other countries. It just seems so counterintuitive not to treat fever. But again, treating fever, as we know now, can prolong and worsen illnesses. Okay, next question. Does emergency do anything to prevent a cold? Is there evidence to prove that, to prove this? This has come up actually in many studies and is actually a chapter in my book under sort of common beliefs that actually aren't true. Another one, by the way, is that teething causes fever, which has been shown in clear studies not to be true. So vitamin C, the notion that vitamin C could treat or prevent colds was born of Linus Pauling. So Linus Pauling was a brilliant man. I mean, he won 2 Nobel Prizes. I mean, you know, that's not easy. The first was for his work figuring out sort of the secondary and tertiary structures of proteins, the so-called alpha helix. I mean, that proteins could have an alpha helical structure. That enabled us to solve the structure of DNA. He won his second Nobel Prize for his peace activism, especially regarding the Vietnam War. 2 Nobel Prizes for a brilliant man who then in his mid-60s decided that vitamin C was a cure-all. That not only could it prevent colds, not only could it treat colds, but it could treat cancer and virtually every disease of man. He published a series of books explaining that, even though study after study after study showed that he was wrong. And I guess maybe this comes with, there's a certain hubris that comes with winning 2 Nobel Prizes, that, you know, if you win 2 Nobel Prizes, you figure pretty much anything that any notion that you have has got to be correct. And even if data show that you're not correct, the data may be wrong. But there are surprisingly 50 studies, meaning placebo-controlled studies similar to the ones that I just talked about, that clearly have shown that you are no more likely to prevent your cold or treat your cold if you receive vitamin C or if you don't. The best study was actually one done at the University of Maryland a number of years ago. And although you could argue there are no perfect studies, this was as close to a perfect study as you could get. What these researchers did at the University of Maryland was they took volunteers and they watched them every day. So first what they did was they took blood samples to see whether or not they were susceptible to a virus called rhinovirus 44, which is a common cold virus, a specific type of rhinovirus. And there's many, many types, really more than 100 types of rhinoviruses, to make sure that every one of them was susceptible to this virus. Then what they did was they inoculated them with this virus at a known amount. So now you know they're all susceptible, and you know that they're all getting the same dose of virus inoculated into their nose. And then either before or during that infection, they gave them up to 3,000 milligrams of vitamin C. And then every day, the physician would go in and monitor their symptoms. So this alleviated several of the biases that are typically in studies, like people are challenged with different viruses. People are challenged with different doses of the same virus. People have different susceptibility to viruses, cold viruses. This controlled for all of that. And when people report their own symptoms, sometimes they're not perfect about reporting them. So here you had a physician then examining the patients every day. And there was no advantage to vitamin C either in preventing or treating colds. It is remarkable to me, one, that people keep doing these studies. I mean, there have been 50 published studies, prospective, placebo-controlled studies showing that vitamin C doesn't work. And if something doesn't work, either one of two things is true. It will do nothing or it will do harm. And when you take large quantities of a supplement like vitamin C, which is not how you typically get it. I mean, when people take, say, the Emergen-C, which is usually about 1,000 milligrams, I mean, you would have to eat 14 oranges to get 1,000 milligrams of vitamin C, or 8 cantaloupes to get 1,000 milligrams of vitamin C. You're not meant to eat 14 oranges at once or 8 cantaloupes at once. It is an unnatural thing to do. It remains remarkable to me that this industry continues to be able to sell itself as natural when it's anything but natural. So no, it doesn't work, and actually increases the risk of kidney stones, especially in younger people. So I would say the issue is clear. And this has come back actually with the COVID-19 story. People have asked whether or not vitamin C is of value. And it isn't. So that's an easy one. Okay, so getting to the questions that I knew would be asked because we were in that time was realistically, how soon until a COVID vaccine, and will it be more effective than the flu vaccine? So I'll answer the second part of the question. The flu vaccine is currently about 50 to 60% effective at preventing moderate to severe disease associated with influenza. I think there's every reason to believe that this vaccine, if it's developed, will be more effective than that. How long will it take? I actually just got off a conference call with Francis Collins, who's the head of the National Institutes of Health, and a representative group talking about trying to be as efficient as we can to get a vaccine available to the public. Remembering that this is a vaccine that will be given to hundreds of millions of people and arguably a billion people. This is a worldwide pandemic. Let me put this in perspective. The fastest vaccine ever developed was a vaccine developed by Maurice Hilleman in the mid-1960s. He isolated a mumps virus from his daughter in 1963. He then weakened that virus in the laboratory, and that became so that it could induce an immune response without causing disease. And then that became a commercial product in 1967, 4 years. 4 years is the fastest time a vaccine ever got made, and this was in the 1960s, when the regulatory burdens by the Food and Drug Administration were far less than the regulatory burdens by the Food and Drug Administration now. That said, I think that the Food and Drug Administrations will be working with pharmaceutical companies to make sure that this vaccine can be out there as quickly and efficiently as possible. But again, here's what I would say. There are 4 current strategies to make a COVID-19 vaccine. One is one that we have ample evidence for it having worked with other vaccines, like it's the so-called purified protein approach. So the good news about a COVID-19 vaccine is you know what you're trying to do. You're trying to make an antibody response to that spike protein. You see on pretty much every media report, you see a picture of that virus. It looks like a little ball, crown, hence corona, and it has these little sort of spikes coming up out of it. See the enormous amount of money I spent on this particular graphic. So it has these little spike proteins that come out of it. If you make antibodies to that spike protein, which is the protein that attaches the virus to the cell, therefore you'll prevent the virus from binding this to the cell and entering the cell, and you'll therefore prevent infection. So that's the goal. Make an antibody response to that spike protein on the surface of COVID-19. One way you can do that is use a purified protein approach, which is what we use for the hepatitis B vaccine and the human papillomavirus vaccine. In both cases, those proteins are the protein that attach to viruses. And in both cases, they induce antibody responses to the protein of that sits on the surface of the virus that then won't allow the protein of the virus to enter cells. Those proteins, though, are so-called virus-like particles. So the conformation of those proteins is exactly as it appears on the virus. Therefore, you don't have to worry about whether it's any different from the way that it would be seen on the virus. I think that's not true for this, that it may be somewhat conformationally different. So that's a challenge. The other strategies that are used is so-called messenger RNA, which expresses that protein. So you inject people with this messenger RNA, which is then translated to the protein, and then you make an immune response. We don't currently have an mRNA vaccine. The second approach is a DNA vaccine. You inject with DNA, which then is transcribed to messenger RNA, which is then translated to the protein, which then induces an immune response. This is an approach that's made by a company called Inovio, which is in Plymouth Meeting, and David Weiner at the Wistar Institute is taking the lead on this. We also don't have a DNA vaccine, so this is another novel platform. The fourth strategy would be, so you have mRNA, DNA, purified protein. The fourth strategy would be a vectored approach, which is sort of the approach that's used for dengue. It's the approach that's used for Ebola, which is you have a different virus into which you then insert the gene that codes for the protein, that spike protein. At least there's a history with that. But so we'll see. I mean, I think that when Dr. Fauci gets up in front of that task force and says 12 to 18 months, I think that is ridiculously optimistic. I mean, I would be surprised if we had something in 2 years, but it's possible we could have something in 2 years. So let me go, I guess with one more question. Julia, we'll do that. One more question, then we'll wrap up. So this question is again sort of about the anti-vax community. Do I ever see a day where anti-vaxxers are no more? I think that'll happen when the sun burns out. I don't think that's going to happen before that. Anti-vaxxers have been around since the first vaccine. Anti-vaccine groups were formed right after the smallpox vaccine, which was developed in the late 1700s. There were anti-vaccine groups that were around in the early 1800s in response to that vaccine. I think that people will oppose vaccines for as long as they're mandated. I think if you ask anti-vaccine activists, what is it that they want? I think they'll all say the same thing. We want vaccines to be optional. We don't want to be told that we have to inoculate our children. We want freedom of choice, which would be fine if that choice didn't also involve others. I think and I'll close with this, I think the thing that most upsets me that anti-vaccine activists says is when they say, what do you care what I do? You're vaccinated, which makes two false assumptions. One is that all vaccines are 100% effective, which they're not. The measles vaccine is about 95% effective, which means 1 out of every 20 people who get it may not be protected. And not everybody can be vaccinated. There are about 500,000 people in the United States in this population of over 300 million people that can't be vaccinated. They depend on those around them to protect them. They depend on the herd immunity or community immunity to protect them. And I think when we don't do that, we put those children at risk, and those are the people who are most likely to be at risk. So I think you have a responsibility. I don't think it's your inalienable right as a United States citizen to allow your child to catch and transmit a potentially fatal infection. So I think that when people choose not to do that, when they choose to not frankly be a member of society that is also willing to protect these vulnerable children, then you have to have laws, because I think there are laws that then protect those children. So that's how I see it. I'd like to again thank Julia and thank the College of Physicians of Philadelphia for doing this. I think this is their first effort at trying to do this kind of thing, but you know, we now are in a new normal with regard to the way we're doing things, including apparently promoting books. So thank you all, and stay safe.
Thank you so much, Dr. Offit. And I just want to make sure for the next slide that you show where you can buy your book online. So you can just put in mooter.org /buy overkill, and that'll take you right to the page to buy your book, which I hope everyone does, because that was a great presentation. So thanks again.
Thank you.